Good afternoon, everybody. I'll be presenting few cases of ambiguous left main, in which how imaging, physiology helped me in making the right decision. The first case is a case of a 63-year-old gentleman, hypertension, a doctor by profession. He had chest pain off and on. The TMT was borderline. LV functions were normal. His angio was done outside, which showed us 50-70% osteal LMC stenosis. So he was advised either a bypass surgery or a PCI to left main. So he was referred to us for a bypass surgery or left main or angioplasty, whatever I suggest to him. So I was not convinced with the percentage stenosis. Once we repeat the angiography, and this is the baseline angiography. Now here again you can see the percentage stenosis appears to be around, it is ambiguous, it's around 50-70%. I was not sure. So is it looking significant? Should I do an intervention? I thought let's do a imaging first and then decide whether this gentleman requires an intervention or not. So how does imaging help me? When we did the imaging, this is the HD IVUS imaging from this pullback from the LAD to LMCA. Now again, I was at the crossroad. The diameter, the MLA which was seen at the LMC ostia was almost 6, 5.9 to 5.9. It's almost 6, you can say. So now what to do now? I was showing an MLA of 6 millimeter. Angiography, it's ambiguous left main. Symptoms were also ambiguous. TMT was borderline positive. Everything was borderline in this patient. What to do now? So still no answers. Then I proceeded further to do an FFR in this patient. So in this case, whenever we see this borderline areas between 4.5 to 6, best is to do an FFR, do a physiological testing to assess whether this lesion is significant or not. So I proceeded ahead and did a DFR first, which was 0.96, which is insignificant. FFR done again, which was around 0.95, which is not significant. So if we summarize this case, a gentleman had a 70% osteostenosis in angiography, referred for bypass surgery, did an IVUS which showed a borderline MLA of 6, did a physiological testing which showed insignificant FFR and both DFR. So patient was managed medically and bypass or any intervention was avoided. So this is how imaging in both physiology and imaging helped me in planning the right strategy for this patient. A second case again. This is a 71-year-old gentleman, again had a left main osteal stenosis, which is again borderline, which is not sure what to do now. He was hypertension, diabetes, but he had classical angina. Now again an IVUS done, pulled back from the LAD. Again the IVUS showed an osteal. If you see the MLA at the ostium of the left main coronary artery, it's again 5.87. So again, if it is between 4.5 to 6 MLA, again we are not sure what to do in this patient. Again I did a physiology testing. This is the resting physiology DFR I done. It was 0.83. So any value of less than 0.89 is significant. So went ahead and did the angioplasty in this patient. And this was the pre-MLA, and this is the post-MLA after doing angioplasty. A very good result was achieved and patient was relieved of his symptoms. This was the second case. Now the third case is also very interesting. Now this is a 61-year-old gentleman, diabetic, hypertensive. He had angina on effort. TMT was strongly positive. This is the baseline angiography again showing, again we are not sure again. It's difficult to assess on angiography whether the LMC is significant or not. It appears to be around 60-70%, but you are not sure. So again, did an IVUS pullback now. Now again, in this IVUS pullback, again, if you see again, you can see the running pictures. I can show the static pictures also. Now if you see the exact at the LMC ostia, the MLAs were around 6.5. Now again, what to do now? But this patient had a very strongly positive TMT. On the stage 1, it had a significant ST depression, classical history of angina and effort. Ideally, FFR should be done to assess this lesion, but Since the FFR was unfortunately not available at that moment with me due to technical reasons, though the MLA was 6.5 on IVUS, but still, since the TMT was strongly positive, I went ahead and did the angioplasty in this case. Because the cutoff of 6, more than 6, we say of MLA, a patient should be managed conservatively. But there are certain gray zones also. It is not hard and fast that the MLA is 6, you avoid intervention. Because in certain category of patients who are diabetic, who have a high body size, such as in our case, he was more than 6 feet tall, with high physical activity, with high plaque burden in that area, with thin cap fibrous adenoma, multivessel disease. And these are the category of patients we have to be liberal. Even beyond 6, we should do intervention in LMCA, which I did in my case. So I went ahead and did an angioplasty to the LMCA. This was the final LMCA which I achieved, was around 7.39. The original LMCA was around 6 to 6.5. So this was the original size of the LMCA which was achieved. This was the angiography this is the pre-LMCA. I was before doing angioplasty, and this is the final LMCA in this third patient. I did a TMT, within 1 week I did a TMT, to be very sure. The TMT was negative. He could walk in the more than third stage, he could easily walk. Prior to that, on the first stage of TMT, it was strongly positive. So the point of interest is, osteal LMCAs are very difficult to assess by angiographic alone. For ambiguous left main, FFR is the gold standard to decide the severity and to decide the physiological significance of the lesion, to decide to intervene or not. IVUS alone may not be sufficient to decide whether to intervene or not, and clinical scenarios should always be kept in mind, and one should treat the patient, not the numbers only. Finally, just to conclude my talk, intracoronary imagings are the glasses of modern-day intervention cardiologists who do not like blind decisions. Thank you.